Hello, I'm Dr. Richard Becker, Physician-in-Chief and Director of the University of Cincinnati Heart, Lung, and Vascular Institute. Today I'm joined by two colleagues, Dr. Lewis and Dr. David Feldman. We'll be discussing advanced cardiovascular therapies and what the future may hold here at the University of Cincinnati Medical Center. Gentlemen, welcome to Scholarvision.
Thank you very much.
Thank you.
I'd like to begin by asking a fundamental question about advanced cardiac therapies. Dr. Feldman, can you tell us a little bit about the types of diseases and conditions that will be treated here?
Sure. So, as most of our population is aware, the majority of the deaths in the United States, are related to a cardiovascular type of assault. Assault defined as something that's happened bad to their heart, and we have a superior group of cardiovascular physicians and clinicians throughout the area and the region that are excellent at handling these things. On occasion, there is a cohort of patients that do poorly and that with best medical therapy do not get better. This is where Dr. Lewis and I's job begins. And we deal with complications or progressive disease that does not respond to conventional therapy. These include complications related to heart attacks, congenital diseases, family diseases, frankly, patients that just aren't doing well with good doctors and good clinicians.
Mm-hmm. So it sounds like the most complex cases will be coming to the University of Cincinnati Medical Center. And Dr. Lewis, tell us a little bit about the kinds of therapies that will be made available to these very sick individuals.
Well, first of all, advanced heart failure carries a very poor prognosis. We're talking about survival in the range of 2 years, which is worse than most cancers, save pancreatic cancer. So to treat these patients, you really need a full armamentarium of therapies, and that's what an advanced heart failure practice does. And at the base of that pyramid, of that therapeutic pyramid, be diet modification, medical therapy, and as we start increasing the level of therapy for the level of sickness, you go on to cardiac resynchronization therapy, more advanced heart failure treatments, and at that apex of the pyramid is really the surgical therapies for advanced heart failure, be it mechanical circulatory support, the implantation of a heart pump, or at the top of that apex of the pyramid is heart transplantation.
Yes. And Dr. Feldman, let's talk a little bit more about those advanced therapies. Things like extracorporeal membrane oxygenation, left ventricular assist devices, transplantation. Can you help our viewers understand some of those options a little bit better?
Sure. Extracorporeal membrane oxygenation, or the term that's thrown around is ECMO, it's a lot easier to say, is it provides mechanical support which can provide both cardiac and pulmonary support for a patient acutely when they are about to die or have died within a very brief period of time. It has been a game changer in our ability to actually resuscitate and bring patients back that otherwise would have died in the field or acutely in the hospital related to something that happened to those individuals. The ventricular assist devices, or VADs is the term that people throw around, are heart pumps, and they provide a degree of support where you have a mechanical device that's actually implanted in your body, which allows you to leave the hospital and live a modified but relatively normal life with a very, very poor heart, with the pump taking the place of most of the blood pumping for your body.
Mm-hmm. And Dr. Lewis, you mentioned heart transplantation being at the top of that pyramid. Where do we stand in the United States and in this region in terms of availability of donor hearts, and how often do we feel that that will be the optimal therapy for the patients that we've been talking about?
Well, heart transplantation is a palliative measure. You're trading diseases. You're trading the disease of dying of heart failure for the disease of living with immunosuppression. In the United States, there's roughly 2,500 heart transplants performed a year. with at least double that on the waiting list. And the majority of those patients on the waiting list will die waiting for a heart. What we found is through the use of mechanical circulatory support, the use of implantable ventricular assist devices, or VADs, we're able to take patients that would not otherwise be good candidates for heart transplant and make them into good candidates for transplant. At the same time, we're also able to save patients who otherwise would not be good candidates for heart transplant and treat them with the device long term, and something that's called destination therapy.
Mm-hmm. So as a strategy of bridging, or as therapy in and of itself, such as destination. So
That's
we
correct.
have options. And we have some newer generations of devices, and perhaps Dr. Feldman, you can tell us a little bit about how the field has evolved over the years from first to second and perhaps a third generation.
Sure, Dr. Becker. First, I'd actually say there's a third group of patients who actually receive these heart pumps, and those that we actually believe may recover, and the ventricular assist device can be taken out without the need for either a heart transplant for the hearts to support themselves. Mm-hmm. And through the utilization of either cell-based therapies or to prop patients up where they would otherwise be too weak to get the cardiac support they needed to heal their heart, the ventricular assist device allows them that ability to give them the time and the support they need to let these other therapies work on a molecular level. It's been a very complex field that has evolved over many decades, and like many technologies, it has only come to the surface to most people's vision in the last 10 to 15 years. What we've seen is we've seen pumps that were the size of a table, that had tubes that were put in people's hearts that would never fit in their bodies, that would never allow them to leave the hospital, that required extreme degrees of blood thinners, and we are now gravitating towards pumps that are the size of your fist, that are implanted next to your heart, with long-term goals being eventually to develop longer batteries and implantable devices where the entire system is held within your own body, just like a pacemaker.
Mm-hmm. So incredible progress that has been made to serve the patients. It's clear to me that not anybody or just anyone can do these types of procedures. So Dr. Lewis, can you tell us a little bit about, from a surgeon perspective, the kind of training that's required to do the things that you do? And then I'll ask Dr. Feldman to articulate from a cardiologist perspective the skill sets that are required.
Well, to be able to put in one of these devices, you have to be a fully trained cardiac surgeon, and also have additional training particular to this field. I think that's very important. But it's not enough to just break it down and say what you have to do to implant a VAD in someone. I would say anyone can do it, but obviously that's not true. What's important is, what do you have to do to have the patient be successful on a device? And that means to live a life not just longer, but live it better. And in order to do that, it really takes the building of a true multidisciplinary team. A team that involves an experienced heart failure cardiologist, as well as an entire team filled with nurses, nurse practitioners, intensive care physicians, dietitians, social workers, psychologists, infectious disease doctors, and the list goes on. But really getting an entire team where you're able to call on the particular expertise of each individual of that team in order to stand by and make this patient be successful and support.
Yep.
So I would say the easiest part of putting a patient on support is putting the device in. Now, that's not necessarily true, but it's an important part. But the more important part is really having that team in place to make the patient be successful and support.
Yes, and when all said and done, it is about the patient, and I suspect about patient selection in terms of, for this armamentarium, what is the right form of therapy for that patient at that particular time, and then of course to be followed very, very closely because their conditions can change. So, Dr. Feldman, tell me a little bit about the training that we will offer here, or the kind of training that is required of a person to serve on this very special team that Dr. Lewis described to us?
Sure. I'll amplify some of Dr. Lewis's thoughts by saying all the cardiologists that do this are boarded in internal medicine. They then have to be boarded as cardiologists. They then subsequently have to do a fellowship training thereafter. Our patients, I think, now are becoming more and more savvy consumers. I would encourage them to look on publicly recognized websites to make sure that their physicians actually are boarded in their subspecialty. Like Dr. Lewis said, it's not enough to be capable of doing it. You want to be surrounded by a team who does it well, and you want an experienced team. And the ability to actually look into the results of those actual programs, I think is particularly relevant, because when you're treating every patient as if they're a member of your family, you want to make sure that you actually have as much information as possible before you go to a medical center. In any given state, there are usually only 4 or 5 hospitals that will do this. In some of the more populated states in the Northeast, there are up to 10 programs in a state. But the number of programs in any given place is actually much smaller than you imagine it would be, because it takes so many resources to produce the results for a single patient.
Yes.
It takes a small village.
Yes. And that's something that certainly has been assembled here and is being assembled here. And yes, the outcomes are important, and of course all of those are tracked very, very carefully by a number of governing bodies in the United States. As a last question, we're here to serve the people of our community, people of our region and beyond. Dr. Feldman, what would you like the people of our community and region to know about this program that is being built here at the University of Cincinnati?
We build the foundation of this program on taking care of the most difficult cases, the most complex, as well as the ones that we believe to be more straightforward. We base this on data, clinical trials, molecular biology, and the personal touch of treating everybody as if they're one of our own. Doing that and implementing that in an integrated style is what we're looking to do to build this program further and to support our community. It is the only academic medical center in this region of Ohio that is looking to serve and build a program like this right now.
Mm-hmm. And Dr. Lewis, what would you say to the people that we serve?
That we're not just, the people come to us wanting to survive, because they most often have been given a diagnosis that's a life-limiting diagnosis. And what we're trying to build here is not something that's just going to help them live longer. We want to help them live better. And we want to do that in a truly multidisciplinary approach, building on technical surgery, technical cardiology, at the same time all those other aspects of medicine and the care of human beings that can't be quantified, to truly build a multidisciplinary, top-notch advanced medical therapies program for congestive heart failure.
Sounds like something special is about to happen under this roof. And gentlemen, I'd like to thank you for joining us today on Scholarvision and sharing some of your thoughts of something that sounds very, very special. And thank you all for joining us. Until next time, keep asking questions. Inquiry is the true compass of scientific and medical advances.